Good afternoon, everyone. This is Bevan Buchheister, Senior Policy Analyst for the National Governors Association Center for Best Practices. I want to thank Governor's Health and Water Advisors for joining the National Governors Association's webinar today to learn from 3 states, Utah, Colorado, and Maryland, about their programs to test wastewater for COVID-19. Because many people may be infectious with COVID-19 before showing symptoms, testing wastewater can provide states and localities with advance notice of the presence of COVID-19 in a community and can show whether cases are increasing or decreasing. As we head into fall and winter, this may be one of the valuable tools to address anticipated spikes. The CDC is also starting a national wastewater surveillance system, which is a nationwide effort to collect and normalize data. And EPA is working with CDC and doing research to standardize assessment methods. But the states, as we know, are laboratories of innovation, so that's going to be our focus today. 2 of the states, Utah and Colorado, have stood up their programs statewide, and Maryland has just completed a pilot phase. So we thought it would be valuable for you to get perspective from states that are in different phases of their programs. We asked each of them to tell us how their programs are organized, deployed, and funded, and to tell us how they plan to use the data to inform their response to COVID-19. We've also left about 15 or 20 minutes for Q&A to answer your questions. So please use the chat box or the Q&A box to ask questions throughout the presentations. I'll be posing your questions to the speakers after each presentation and during the Q&A session. So now I'd like to introduce today's speakers. Next, okay, thanks. From Utah, we have Erica Gaddis. She's the director of the Utah Division of Water Quality for the Utah Department of Environmental Quality. She became director in 2017 after serving as assistant director for 2 years. And prior to that, she worked as a consultant with expertise in water resources and water quality. We also have Dr. Nathan LaCrosse, who is an epidemiologist with the COVID active response team at the Utah Department of Health. He's been with the Department of Health since 2013, and since March 2020, he's been working on the COVID-19 surveillance and assisting the state's pandemic response. Next slide. From Colorado, we have Nicole Rowan, and she is the Clean Water Program Manager for the Water Quality Control Division at the Colorado Department of Public Health and the Environment. She oversees the implementation of the Clean Water Act and the Colorado Water Quality Control Act. We also have Dr. Brian Early, and he is a medical epidemiologist at the Colorado Department of Public Health and the Environment, where he works on disease monitoring for COVID-19, influenza, RSV, and other respiratory viruses. His previous research included geospatial modeling of environmental health risks. And from Maryland, we have Suzanne Dorsey, the Assistant Secretary of the Maryland Department of Environment, joining us. Her background includes research science and coastal oceanography and marine science, grassroots environmentalism, education, and public service. At MDE, she works with the Water and Science Administration on Chesapeake Bay restoration and on major issues that require cross-agency collaboration like climate change, water quality, nutrient trading, and wastewater surveillance. So now I'd like to invite our speakers from Utah to begin their presentation and tell us about their program. Next slide.
Great, thank you, Bevan. I'll get started here. This is Erica Gaddis from the Division of Water Quality. You can see here on our title slide the number of organizations that have been involved, and I'm looking forward to going through that with you. Next slide. So just to make sure everyone's on the same page, we're talking about sampling wastewater influent. So those are the sewer lines that are coming into our wastewater treatment plants in our communities. They can be thought of as sort of a collective sample, if you will, or a pooled sample of all of the homes and individuals that are using that sewer system. In this diagram, you can see a hypothetical number of homes with COVID-19 in red and others in blue, and the proportion of virus or the amount of virus we find in the wastewater as it comes into our treatment plants gives us some measure of the prevalence of the virus at the community scale. This is not a new idea. It's something that's been used in other contexts in the past. It's been used for polio monitoring in some countries, and in the Midwest recently, has been used to track the opioid epidemic in some communities. Next slide. So I want to go through the way that we have approached this from a statewide perspective. Our goal all along has been to support Utah's response to the COVID-19 pandemic by tracking trends primarily in wastewater virus concentrations across the state. This map here shows the great state of Utah. We're a relatively large state geographically, and you can see we're sampling 30 of our larger wastewater treatment plants that typically serve more than 10,000 people. In addition, we've selected 14 rural treatment plants that serve a smaller population, but were selected either because they're in tourist areas where there's a concern that virus concentrations may be coming in through tourism, or because there might be some other risk factor in terms of outcomes, or in some of these places we have meatpacking plants that present a risk to those communities. In total, these sampling sites cover about 85% of Utah's population. We stood this up after a short pilot study in April and May that was a 6-week study at 10 facilities, and then we broadened it to these 44. We sample weekly. We've been doing this since July, and we're funded to go through the end of the year through December. We also have capacity in our laboratories to sample provide additional samples every week as needed that's requested by our 13 local health departments. Our samples are analyzed by 4 university laboratories that are distributed across the state quite conveniently, one down in the southern part of the state, Dixie State University. We have BYU, Brigham Young University in Provo, University of Utah in Salt Lake City, and then up north we have Utah State University. In total, our costs are estimated for the full 6 months at $475,000. I want to emphasize that a lot of our costs are going into sample collection and transport. Just getting the samples from some of those remote areas of our state up to our laboratories within a day is quite expensive. We've been using CARES Act funding, and we will continue to use that through the end of 2020. Next slide. Won't go too far into the analytical methods. These are the methods that our laboratories developed during the pilot study in April and May. I do want to point out that the RT-qPCR method is the same method that's used in clinical tests for COVID-19. It's the preparation of the sample that's a little bit different through centrifuge and filtration. There are a lot of different ways to prepare these samples, and that is the subject of what CDC and the Water Research Foundation has been looking at. We thought it was most important getting started that we have a consistent method so that we can track trends over time. And Nathan will talk a little bit more about how those trends have been informing some of our health decision making. Our results come out in gene copies. So we're looking at the RNA or the genetic material of the virus per milliliter of water sampled. And then we are converting that here in Utah to number of gene copies per 100,000 people. We know how many people are in each of the sewer sheds, if you will, or the areas that are served by each of those different treatment plants. That standardization has really helped us to account for changes over time in the infiltration of water into our sewers and industrial flows across different types of treatment plants around the state. Next slide. We've stood up a data dashboard. This is our public-facing dashboard, and you can see on the left, this is just a snapshot from Monday. You can see we've got all of our facilities on the left, and we are flagging those that appear to have an increasing trend, a decreasing trend, no trend, or not sufficient data to make a determination. So that's live, and the public has access to that, as well as our health departments. Nathan, who will speak later, also analyzes the data in a little bit more detail for the local health departments. This data set here shows all of our data from May through October for the Salt Lake City Water Reclamation Facility. On that top plot, that gray line tracks the state average for each sample day. And then on the bottom graph, you can see the number of infections for that same sewer area. And that's really helped us evaluate whether we're seeing a trend that can be confirmed with case counts, or if we're seeing something early You can see, I'm sure many of you may have heard in the media that we have had quite a spike here in Utah in the last few weeks, and you can see that in the Salt Lake City data in late September and early October. Next slide. In terms of the way that we've organized our approach, we're going to have 4 players. We have the wastewater treatment facilities themselves. Those 44 facilities are collecting the samples themselves as part of their normal sample collection. And it's been really important for us to try and tie into sampling that they're already doing to ease the burden on those facilities. My division, the Division of Water Quality, has been serving in a role of project coordination, data management, as well as sample transport. So we have hired 2 temporary employees that basically are driving around the state every day, picking these samples up and returning them to the laboratories. The 4 universities I mentioned are doing the sample analysis and participated early on in the development of our analytical methods. And the Department of Health, who you'll hear from here in a few minutes, is doing much of the data interpretation and then communicating the meaning of that information to our local health departments, as well as to our response teams. Next slide. Just a couple notes on things that we're also exploring. University campus sampling. All 3 of our large universities are sampling dormitories and other areas of their universities. That's not something the state is directly involved in, but we have been tracking that, and it has provided some useful information to university decision making. Next slide. And finally, we're looking into whether we can use this technique to go to a finer scale. This is our largest facility in the state, just shows all of the different areas that come into one treatment plant. And we have been able to, in the past, sample different lines of sewers coming into that treatment plant to try to differentiate and get a little bit more spatial granularity in terms of the data. So we're still working on that. Lots of opportunities for this to be used, and I'll turn it over to Nathan to talk about the health department's perspective.
Thank you, Erica. It's Nathan LaCrosse from the Utah Department of Health here. If you go to the next slide, please. So before I get into some of our data and some of the use cases and how we're using the data, I want to talk briefly about some of the potential limitations and some ways to help interpret the data. I think it's useful to have that as context before you actually start looking too much at the data. So one thing to keep in mind is that there is often quite a bit of variability in the data. It goes up and down from a sample to sample basis. And there are a lot of different sources of this variability. This is by no means an exhaustive list. These are just the ones that I could think of off the top of my head. But there are very likely a number of other ones that and we are not as aware of. So some of these sources of variability are environmental. So the infrastructure between different sewer systems can be quite different, both in age, in permeability to permeability to runoff and groundwater, how long the wastewater takes to go from a particular point to the actual influent sampling point, because the viral RNA that we're detecting does degrade over time. How warm the water is, the viral degradation increases with increasing temperature. What other constituents there are in the wastewater stream that could also influence degradation or recovery. And if there are industrial sources that contribute to the wastewater. Some of our sewer districts have significant industrial sources, and this can sort of skew the data when a significant portion of the wastewater isn't actually coming from residential sources that would presumably at least sometimes contain remnants of the virus, but industrial sources which probably wouldn't. There are also biological sources of variability. So which people or populations tend to shed the virus. It's probably not all people all the time, even if they're infected. How much virus is shed, how long the virus is shed. And so because of all these differences or potential sources of differences, I think at this point, currently, the data is not particularly easily compared between different facilities. So we don't really try to do that because it's hard to say what a given level means in facility A versus that same level in facility B. It might be high in one and low in the other one. So really what we're doing and what I think is more useful at this moment is to look within a single facility over time to see how those levels in wastewater are changing. And of course, comparing it to cases that have been identified within that same sewer shed area. And then, of course, as with most surveillance data, I think that the wastewater data is best interpreted when possible in conjunction with whatever other sources of information you may have that's available. So information about other events or things that are going on within that sewer shed can really help interpret what you see within the data. All right, next slide, please. Okay, so a few use cases with some data examples. So I think one of the most prominent ones, and certainly one of the most useful ones, is using wastewater surveillance as a means to detect early areas that have rising infection rates. In many situations, increases in wastewater levels will precede increases in identified cases through the normal clinical testing by, in our experience, perhaps 4 to 7 days, something along those lines, which you can see in this data below. So this is from Provo, a fairly major city. This is one of the areas that first experienced our recent surge in cases. Most of them were in Utah County. This is where the Brigham Young University is. And early on, this surge was really driven by high school and college age people. And it's kind of harder to see in that top graph. The top graph, I should mention, is the wastewater data. The bottom graph are daily case rates within that same area. And you can see the map on the left there. So because the wastewater levels eventually got really very high, well over 1,000 million gene copies per person per day. We actually started looking more closely at this site around the August 18th sample. It doesn't look very high now because, again, levels ultimately reached much, much higher. But at the time, that was enough of an increase that caught our attention. And sure enough, that did in fact precede the rising daily case rates within that same area by a reasonably significant period. So using it in this fashion can allow you to more quickly identify these areas and thus more quickly implement interventions that may help bring down the case rates within that area and reduce transmission. Next slide, please. Another I think very useful area, especially in some of our more rural locations, is to use as a way to fill in gaps in monitoring using the more traditional clinical testing when that type of testing isn't as available. So we know, certainly in Utah, I suspect just about everywhere, that clinical testing is not equally distributed throughout our state. There are areas where it is more easy to get one of those tests, and there are areas where it can be quite difficult because sometimes they're just not, those researchers don't really exist in that area. And this type of sampling can be used to help fill in some of those gaps. You can keep an eye on at least a proxy for the infection rates in that area, and then potentially take action and perhaps redistribute some of those traditional testing resources when you identify increases in the wastewater levels, which again, we can see here. So you can see that we caught the tail end of our July surge when we started sampling at this site. And this is in Blanding in southeast, Utah. It's by car about 6 hours away from Salt Lake City. It's a fairly major city for the area, but as you can see, it's still quite small. And once the levels dropped from that July surge, they were at non-detect. We didn't find anything for quite some time until the most recent sample at this particular location, where it jumped up significantly again. And there was an issue with the more recent samples, so we're kind of missing some data at the very end of that plot. But you can see that the case rates also have started to go up a little bit within that same area. So again, the data nicely preceded an increase in case rates. And I should mention this, I mean, it's really the same situation in areas where there might be increased resistance to clinical sampling. Basically, you can help fill in gaps in data where people just aren't getting tested at the rate you would really like. And it's, about as anonymous as this sort of testing can ever get. You're just collecting a pooled sample from the entire area. You have no idea, you have no way to track it back down to individual buildings or people. So next slide, please. Another very useful thing when we had declining case rates was as a way to help confirm that our declining case rates were not simply an artifact of differences in testing. So this is from that same Salt Lake City water reclamation facility that Erica was showing data from before. But this is data from about the end of May. And you can see, again, that July surge in cases that we had. It showed up just about everywhere in the state. Showed up in the wastewater data as well, which is the middle chart this time. The top chart is a graph of the number of people tested per day within Salt Lake County. So this is a larger area than the Sewershed by quite a bit. But I suspect if we had all of our tests, including negative tests, geocoded, we'd see a very similar pattern within the specific Sewershed I'm demonstrating here. But what you can see is at the bottom graph, the case rate graph, that it starts declining right around the early mid-July or so, which was great. We love to see the case rates go down. But unfortunately, what we also saw, if you look at the top chart, is that the number of people tested per day was also going down. And this happens for a variety of reasons. When those two patterns coincide, there's always the worry that we're only seeing decreases in case rates because we're not testing as many people anymore. If you don't test for them, you're not going to find them. We were able to look at the wastewater surveillance data, which also dropped significantly and then stayed low, to help support the idea that this decrease in case rates was probably real and not just an artifact of changing testing patterns. Next slide, please. And then the last example, certainly by no means, well, the last example with data I'm going to go through real briefly is it can, whether you want it to or not, capture transient events. So this is a small city called Price. It's in the middle of the state, and it is a place that a lot of people will pass through, not necessarily to get to it itself, although it's a fine place to visit, but as they're traveling down to the southernmost parts of the state. The I-15, a major freeway, runs along north to south along the western portion of the state. And if you want to go south in Utah, but aren't on the western portion of the state, you're almost certainly going to pass through Price. And if you do, you're probably going to stop and use the restroom because this is one of the few places to do so on that route in this area. And we can see some interesting patterns in the data. Probably, this is a supposition, but I think it's a fairly strong one, probably because of that pattern of travel. So we can see, again, the daily case rates on the bottom and the wastewater surveillance data on the top here. And we can see some transient spikes in the wastewater data. And those first two roughly coincide with some fairly major holidays. The first one is right around the week of Memorial Day, and that second one in July is right around the week of 4th of July, when a fair number of people travel, either for camping, for recreational opportunities, to visit family. People still do this even during a pandemic, as we all know. And we didn't end up seeing corresponding increases in case rates, as you can see in the bottom chart. And this suggests to me that this is probably capturing very possibly some of those people traveling through and using the restroom. They weren't residents, and so if we identified them as cases through the normal means, they weren't allocated to this specific area because this isn't where they live. But at the time we were sampling, they were traveling through and contributing, so to speak, to this wastewater system. And that's an important point to keep in mind. You're not just sampling the residents in whatever area you're collecting from. You're sampling anybody who's using the bathroom, whether they live there or not, which can be both good or bad, depending on what you're trying to accomplish. And then later on, we can see a much lower, but more sustained increase in the wastewater levels that does better correspond with some increasing case rates we see in that same area. Next slide, please. And so very briefly, some newer uses that I think are also pretty exciting, although also somewhat unfortunate that we have to go to these steps in some ways, that we're using wastewater surveillance data for is one, to help prioritize contact tracing. As our daily case rates increase throughout the state, our contact tracing resources are starting to get more and more stretched. And so we're starting to plan ahead for the day, hopefully it won't come, but the day where we have to start prioritizing who we're actually contact tracing to the highest priority, the ones that are most likely to spread or the ones that are most likely to have severe outcomes. And we're using wastewater surveillance data to help inform some of those decisions, where areas that are seeing either rapid increases or sustained high levels will be given higher priority for contact tracing. We've also used it to help inform identification of high infection rate areas for some proposed really intensive, really door-to-door clinical sampling. This is a proposed project by CDC. I don't know if it's going to happen or not. It's sort of very much in the early discussion phases, but they had an idea to go door-to-door and test as many people as they could to see what they find in terms of what is the actual infection rate in that area, but also if that will help drive those infection rates and transmission rates in that area down as well. And it's been used to help inform the targeting of a number of different outreach mechanisms, health education, so trying to get people to wear their masks, to socially distance, and other interventions as well. It can be a really useful piece of information to inform all sorts of things. Next slide, please. All right, Erica, I think you are probably up first.
Yeah, so just a couple lessons. I know we need to wrap up here quickly. We think a pilot study is really helpful in getting your methods sort of sorted out at a relatively low cost. For us, collaboration has been critical, involving health at the beginning, but also trying to respect that their demands on their time are many. So we've tried to fill in as many gaps in terms of data management as possible. Certainly having wastewater folks involved has been really helpful because we understand some of these caveats and nuances of sewer systems and wastewater. I'll let Nathan finish up.
Yeah, I really want to emphasize that second one too. Like, we have a lot of different partners from a lot of different fields, which is fantastic because they all really bring incredibly valuable expertise, but it's also a lot of coordination and logistical works to get everybody on the same page. And it's extremely important. And Erica already mentioned the really significant logistical burdens just collecting samples and getting them to the lab can present, and that takes a lot of coordination as well. So we have a lot left to learn, I think, about this field. We're still very much in the early days, but even though there's a lot of unknowns, this source of data is already providing really useful information that helps inform public health efforts. And it's going to get more useful, I think, as we learn more and as we develop our systems more as well. The sampling and analytical methods really ideally should be selected with public health uses in mind. That is, of course, assuming that is your ultimate goal, is to help assist and inform what the pandemic response within your area. If you're just gathering data for academic purposes, that's different. But if you are trying to help and inform your public health partners, you really want to work with them to find out what formats are going to be most useful, what timing, what scale of sampling, like how big are the areas. We have some sewer facilities that are extremely large, which is useful for sampling a large portion of the population, but less useful for actually acting on that data because the populations within those large areas are not equal and they don't experience the disease equally either. And as it's very new, it's really important to just be adaptable and to be prepared for rapidly changing science and best practices. Things are changing all the time, which I think is good. It just means that we're learning more and refining things, but you can't learn something and then that's it. That's what we know now. It's going to change every day just about. All right, next slide, please. And that's about it. This is a link to our public dashboard. Once again, we would be happy to entertain any questions you might have.
Thanks, Nathan. This is Bevan. I'm going to just jump in and ask the first question, and that is the examples that you provided in Provo and Blanding. Was the data used by the local officials, or was there any guidance from the state on how to use this data that they're getting? Because local officials are not health experts, and they've probably got a flood of information and all this decision making to do regarding COVID and whether to close things or to do extra outreach to the public and warn the public. And also, this dashboard, what's your recommendation on how much information you give to the public and how you tell them to interpret it and use it?
Okay, so I found that the uptake, if you will, of this data source is certainly variable for the area. We have local health departments and other partners that are, I think, more familiar with using new data sources where they have to kind of figure things out and remember to use it, remember to incorporate it. And there are ones that are less familiar with that and have less resources that they can devote. So it's been variable. I think it is increasing over time, both as they just become more familiar with it and as we increasingly demonstrate its utility. I think with any new data source like this, there's always a period of sort of a wait and see, where they want to see like, okay, so there's new data, but what does it actually mean? Is it actually useful? And I think we're increasingly demonstrating that. So more and more is your answer to your first one. And then your second, we're making just about everything available to the public as soon as it's available to us internally as well. We view it as a useful resource for the public as well, although really I think our primary audience that we're thinking about are really the public health and policymakers that will hopefully use the data to make decisions. But we certainly want the public to take a look at it and help them, because it could help inform their behaviors as well. If they're living in an area, as an example, with high wastewater levels, maybe that would, and hopefully it would make them more likely to wear their masks, socially distance, wash their hands a lot, etc.
Right.
The one exception is, of course, with our daily case rates in these areas, because the areas are quite small. When we have very small counts, those are suppressed. So basically, if there's a count under 5, that's suppressed, and so we'll just show under 5. We won't show the exact number, and that's just our standard data security and privacy policy.
All right, thanks. Erica, there was a question about the federal funding needed for to carry out this kind of a program on an extended basis. And you had mentioned that you all use CARES Act funding for it. And I see in the chat that you said that your costs are running at about $80,000 per month. I know you mentioned at the beginning some wastewater treatment plants were doing work, gratis just to help in the effort. But wastewater treatment plants with the ban on disconnections, water and wastewater treatment plants are getting hit hard. So how is that working for them? And also that $80,000 cost, that is that inclusive of the health side and the wastewater sampling side, or is that just for wastewater sampling?
So great questions. Yeah, that's just the wastewater sampling. It is not compensating the wastewater treatment facilities at all. That has all been in kind. It is true that we're starting to see some fatigue with some of our facilities as this goes on. But that's why we've really tried to target sampling times and dates when they are already collecting influence samples for some of their other regulatory requirements, so that they're just throwing one more bottle into a composite sampler that's already running. Our staff's going to their door to pick it up, so they're not having to do anything more beyond that. But we are starting to see some fatigue. And as we transition, I put in the chat response, we are going to be transitioning to some CDC funds in the new year. And at that point, we're going to be transitioning this whole project coordination and management over to Nathan at the health department. And yeah, at that point, CDC is going to require a little bit more frequent sampling. We'll probably have to look at scaling back the number of facilities. So maybe a different design at that point. We're still kind of working through that. And we may need to explore for some of our facilities compensation for some of the work that they're doing.
Okay, well, thank you. Stay on the line. We want to bring you into the conversation after our presentation from Colorado and Maryland. So now I want to invite Nicole Rowan and Dr. Brian Early to tell us about Colorado's program.
Thank you so much for having us today and letting us tell Colorado's tale. We've really been in the thick of this since with monitoring since late August. So I'm going to talk a little bit about how our effort came to be and the funding, and a little bit about what the wastewater plants are doing. And Brian's going to talk a little bit about what we've been seeing with the data and how we plan to be using it, and kind of next steps and long-term vision. So I think one of the things that is a little bit different in Colorado than Utah and other states is that in Colorado, our Department of Health and Environment are all under the same state agency. So our executive director covers both the environment, the regulatory aspects, and our health side. So that, I think, has helped a little bit in trying to get connections and get this effort going smoothly, because even though we're apart, at least we're part of the same agency and know some of the same people. So that's helped us through networking. One of the things that how this all came about in Colorado was a little bit different than Utah. It was a little kind of a grounds up approach that was taken by the wastewater utilities. So at the beginning of the pandemic, several wastewater utilities along the Front Range of Colorado participated in the BioBot effort out of Massachusetts, where that company was providing sampling of wastewater samples for the SARS-CoV-2 virus at a pretty low cost through the month of May. And at that time, the cost of those samples and participation from the wastewater utilities was going to increase in about an order of magnitude. So we were seeing at that time some of the research out of Europe, and we're talking to our leaders in the department about this opportunity. And at the same time, we were approached by a coalition of wastewater utilities to see if there was a chance to partner on this effort. And so one of the key things when we had those initial conversations that were of great focus was trying to develop some Colorado-specific laboratory capacity and the ability to turn around samples in a short time frame. We were seeking kind of a 3-day turnaround time. So we were able to partner with Colorado State University and Metro State University of Denver, who are helping with the analytics. Similar to Utah, the Water Quality Division has kind of helped coordinate and being a liaison between the wastewater utilities because we have the knowledge of that work. And our health folks are definitely helping with interpreting the information and determining how it's best used and collaborating with our local public health agencies. So we have partnered with 17 wastewater utilities across the Front Range of Colorado, which represents 60 to 65% of our population. And we secured federal funding through partially through CARES and partially through other sources to keep this effort going for the next year. So again, we started sampling at the end of August and plan to go till about that time next year is what we have funding for. Next slide, please. So we have secured $520,000 at this point for this effort, and that is solely going to the laboratories for analytical testing. The rest of the effort is through in-kind services, through our effort to help coordinate and helping on the public health side of things. The wastewater utilities are providing in-kind services through collecting the samples. Again, we've tried to tie this to part of the routine sampling that's required for ongoing operation of their facility and compliance monitoring for the things that we regulate them for. So we are taking 2 samples per week at the influent to these facilities. And the wastewater utilities are also providing in-kind services of getting those samples to the laboratory. And I wanted to just talk a little bit about the collaborative effort with the wastewater utilities. You know, we had this initial set of 17 utilities that we're working with. We meet kind of on a bi-weekly basis to kind of talk through the process and how things are going. There has been other facilities across and counties and regions across the state that are interested in doing this type of sampling and have secured their own funding through CARES and other sources. And they're kind of joining the collaborative so that's all working together, and hopefully the information will eventually be pooled in one location. But at this point, we haven't expanded to any additional facilities outside of the 17 that I talked about here. So I think I'll turn it over to Brian, who's going to talk a little bit more about next steps and the data.
Thanks, Nicole. And I'm Brian Early. I'm a medical epidemiologist at CDPHE. And if I can get the next slide, I'll talk a little bit about what we're doing with the data now and our visions for the future. So as our colleagues in Utah described very well, there's some great things about Sewershed testing, that it's a really efficient way to get a sample from a whole lot of people all at once. But that comes with some challenges. And I think one of the biggest challenges of that is figuring out what this signal means. You're getting a lot of data. We're getting data twice a week from these sewer sheds. And I think these 2 graphs on the left sort of demonstrate some of the challenges we face. The top graph is shows our the amount of virus we detected in the wastewater in red, and cases by onset date in blue, with sort of a bluish smoothing line in there. And you can see that really seems to correlate very well. We get about a week of advance notice when from viral signal when the cases are going to go up, and then they seem to drop off at about the right time. And it works great. The problem is when we look at a different sewer shed, like this one on the bottom left, where there really is very difficult to draw any correlation between that viral signal and the number of cases you're seeing per day. Now, as we've sort of gained experience, we found that some sewer sheds correlate really, really well and some don't. We're doing a little bit of work to try to figure out what factors might be influencing that, and including different ways of analyzing the viral sample, whether it's copies per liter or copies per population, or normalizing using other things. But suffice to say that it still remains a very, very complicated problem. And another, frankly, thing with Sewershed that makes it a little bit more difficult to use is that you're capturing a lot of data from thousands of people. And so any response that you might want to have is to affect what you're seeing in a signal is going to have to affect a very large segment of the population. So it becomes an area where you really want to have a lot of confidence in what you're seeing. And I think, as Nathan pointed out, that confidence comes from sort of looking at these numbers in context, with case numbers, with hospitalization rates, with what you know is going on in your community, to really provide the context to understand the data you get out of just this wastewater sampling. And if I can get the next slide. And as Nicole mentioned, our sort of wastewater collaborative we are not the only group doing wastewater sampling in Colorado. Institutions of higher education, a number of our colleges and universities are sampling at residence hall levels and are actually learning a lot and have become great laboratories for us as we communicate with them about best practices for sampling, both at a large and a small scale, because they can really, if they see something odd, they can walk the 30 feet and see what's going on in that dorm, whether it's, they're cleaning or it's been a recent rain has influenced the sewer shed or something like that. Individual counties have also taken some initiative and have started their own sampling programs or are planning on beginning that. And they're really looking at sampling to guide rapid response to small neighborhoods, those small sewer sheds or small wastewater regions. Sampling neighborhoods they think might be at risk, some of those meatpacking plants that were mentioned earlier. The Department of Corrections has some interest in doing facility level testing and doing some detection in that population. And also, I think, like the other groups, we're very excited to participate in the CDC's National Wastewater Surveillance System, where we can pool our data and our resources and learn from other states what they've found, and start to develop national best practices. If I can get the next slide. When we think about how Colorado is using the data, wastewater sampling is only one of many, many data sources. We just have sort of a sampling there on the right. We have testing data, hospital data, syndromic surveillance, look at mortality and death certificates, we investigate outbreaks. And wastewater is used in conjunction with all those, not in isolation, but as part of our overall surveillance effort. It can alert us to regions of concern, places where we might not have data from tests that show an increase, but we certainly have an increase in wastewater signal, or areas that we find difficult to test for one reason or another. And it can inform us about limitations in some surveillance systems. Why are we not seeing tests in this group when we know that they're having either they're being hospitalized a lot, or when the wastewater signal is going up, maybe that's a testing availability issue. And it can help confirm trends seen elsewhere. And all this data is, as Nathan pointed out, interpreted in the context of what's else is going on in the state and what other indicators say. If colleges and universities just opened up and all of a sudden you see an increase in positive tests and wastewater data, then you have a strong suspicion that it is that college and university population. Whereas if it's tourist season or something else like that, you might focus your efforts elsewhere. And get the next slide. And I want to talk a little bit about sort of our long-term vision, because while we're sort of sampling at these 17 sites and other counties and institutions are doing some local sampling, we we really want to think about what this could look like in the future. And we do want to onboard additional utilities, including utilities that are getting that are sort of further away from our metro regions. We're looking at doing some targeted community sampling, both as part of our collaborative and incorporating data from our county partners, really looking at sort of neighborhood levels sampling, or just smaller regions that are more easy to act on. So instead of trying to create a policy based on wastewater data for a whole county, you can talk about maybe doing some more testing in a specific neighborhood, and figuring out how single facility sampling incorporates into our larger wastewater collaborative efforts. We also want to expand access to our data. We are still developing our publicly facing dashboard and finding ways to make our data more open for community researchers. Some people who are working on some modeling efforts in the community who want to use our data as part of a machine learning effort have reached out about wastewater sampling. And we need to sort of figure out what those data sharing agreements, if any, are necessary. And we want to think about expanding our scope too. I think a lot of people have talked today about the time limitations that's tied with COVID funding, and we'd like this to be part of our COVID toolkit for as long as necessary. But there's also other pathogens that can be detected in the stool. I think about our hepatitis A outbreak that Colorado experienced in 2018-2019 as a pathogen that's very amenable to wastewater testing. Tempe has done a great job of testing their wastewater for opioids and methamphetamine precursors. And that is also another area where wastewater sampling and these abilities we're building up right now in these capacities can have a long-term public health effect. And then human health indicators. There's a test you can get right now for colon cancer as an individual called Cologuard, where they can detect genetic signatures of cancer in your stool, which just goes to show on a small scale what could be done as far as measuring human health indicators on a broader scale, again, through wastewater sampling. All of these future efforts bring issues sort of unique to them, and not that'll take some problem solving, but we've done some really incredible things with COVID already. And I'm excited to see where we can take wastewater monitoring in the future. And I think that's all we have. So we'll have some time.
All right, Dr. Early, question for you. How long does it take to learn if your wastewater data is aligning with the other data that you have, the other data points, like you showed us the two graphs where the top one was really kind of aligning. You could see, the wastewater data was catching COVID cases, and then a week or two later, they were showing up as clinical cases. How long does it take for you all to determine whether it's aligning or whether something is off?
I think, Nathan showed a great example of where the data would never align for very good reason, because it's just transient people passing through a region. And but when we think about analyzing our data, we think about trends and not single data points. We are not at the point, or I think anywhere near the point, where we can look at a single data point and say, I know that based on this sample, X number of people upstream have COVID right now today. But we can look at trends over 3 or 4 data points and say, hey, these seem to be heading up. And then when we have and that takes us, 2 or 3 weeks to collect. And then when we see the case data correlating well with that, we say, well, at least in this short time period, they seem to be matching up well. But if the case data is not changing and the viral data is not changing, then you never know whether your sampling is working well or not. And I think that is something we've learned well from our universities, is that every wastewater shed is going to behave a little bit differently, with a little different level of reliability and ability to predict. And so it's tough to make blanket statements about how soon you'll get useful data out of a system.
All right, and Nicole, I wanted to ask you, I know you had mentioned that the Department of Health and Environment are in one department in Colorado, but wanted to ask you about staff time that it took to stand up this program, and also about, do you have any new full-time employees? Like Utah had mentioned, they had hired part-time employees to pick up the sampling from the wastewater treatment plants. How many full-time employees are working on this, and what were your costs on this?
So to kind of stand up the program, there was 3 of us in the Water Quality Control Division that were kind of working with the wastewater utilities. I would say maybe 10 to 15% of our time at the beginning, and we're probably still putting that amount of effort in just on collaborating, moving forward. It was a little bit more upfront time because we had to establish a memorandum of understanding between the utilities, and then we developed a pretty comprehensive work plan that can help guide not only these 17 utilities, but the collaborative that we talked about as other people join in and are collecting this information. We don't have any new people to keep this going, so we've been doing this kind of at the expense of other work and in our free time to keep this going. And this has been added work to our epidemiology team as well.
All right, thanks. Well, I want to invite Suzanne Dorsey to come tell us about Maryland's pilot program and what they've learned from that and where you're going to go with that.
Good afternoon. It's a pleasure to be here with you, and an honor to be with my esteemed colleagues from Utah and from Colorado. On behalf of Governor Hogan and Secretary of the Maryland Department of the Environment, Ben Grumbles, I'm very excited to share with you where we are in Maryland. Our program really is based on very similar principles to what you've just heard. So I'm going to skip over the details of our original pilot study. I won't go into as great a detail as my colleagues have, but suffice it to say that our original study, our pilot study, which concluded last week, measured the quantity of the SARS-CoV-2 virus in wastewater. And the purpose of the pilot was to monitor infections in defined communities. We did that in both large communities and smaller, more rural communities. Where we're going is taking that data, and some of what you've heard repeated over and over here, in that there are some wastewater sampling pools where you don't get a lot of good correlation. What I think we're finding is that where you can really target your effort, maybe downscale it or sample at a smaller level, you're able to then track your response to the data that you're receiving from the wastewater. So moving forward, we're looking to use pooled data to measure the virus load and rapidly detect and then respond to outbreaks. Next slide, please. So, like the other states, it's really important that I recognize this pilot was done with an incredible pandemic collaboration, which means that instead of requiring MOUs and complex agreements and legal assessments, we had the volunteer cooperation of 5 wastewater treatment plants throughout the state. In addition to Maryland Department of Health, Cliff Mitchell, we had 2 technical staff at MDE, environmental engineers, Dr. Qingzhong Tian and Joey Adia, as well as local government and academic input. We were able to very quickly stand this up, and the total cost of our 90-day pilot was $50,000. So we absolutely had a proof of concept. We learned a lot of lessons, and I want to echo what my colleagues said, which is if you are looking to stand up this type of a program, please recognize that there will be some growing pains in how you sample, where you sample, and then what happens to those samples. So lessons learned were the impact of industrial components of wastewater, which can sometimes cause detection to be inhibited, as well as in Maryland, we have some combined sewer and stormwater systems. So ensuring that you're either not testing after a rain or that you're able to standardize the data relative to rainfall. Those were key aspects to understanding our data and getting good success. In this slide, you do see that we were able to, in our smaller communities, have a very good correlation between wastewater and clinical data. The qPCR viral load was also much higher in our larger, so our Baltimore, for instance, wastewater treatment plant versus our smaller rural wastewater treatment plants. We all are stating very definitively that this is not a tool where you can determine exactly how many people are infected. And it is best used where our clinical data aligns with the resources that we're testing. We also found that it is a very cost-effective pooled monitoring and testing technique, and it can provide actionable information. You may have heard the university examples. Here in Maryland, we also had a county that tested at a university, and they were able to detect asymptomatic shedders. And when they isolated them, there's a very clear outcome that they were able to detect, respond to, and then stop an outbreak at a university. And that's at Mount St. Mary's College. And my colleagues in Frederick County were the heroes that made that happen. Next slide, please. So phase 2, what's next? We've learned a lot. We've determined that this can be very effective, but it's particularly effective in a downscaled setting. So instead of monitoring at the wastewater treatment plants, we're really focused on vulnerable populations, and particularly those vulnerable populations in congregate housing. So we're looking at our prison system as well as our subsidized housing. And we're looking at weekly testing. We're planning to put $1 million towards this project and get it up and running as soon as we can. We have a lot of interest from our congregate housing. Instead of it being a top-down, we're approaching this from an opt-in. Again, we really want pandemic thinking. How do we solve problems, not how do we run into barriers to success? So we're working with management companies, owners of subsidized housing, along with, and this is key, local government health leadership. So in Maryland, we have county health officers. So in collaboration with our Maryland Department of Health, we're working with our local governments to identify key vulnerable populations where we can test at the manhole scale. Next slide, please. So very quickly, once we identify a vulnerable population, we would place a composite sampler at an accessible location that is not accessible to the public, but is accessible to our wastewater engineers. They take a composite sample for 24 hours, which is then processed and delivered to an analytical laboratory. The laboratory has got to turn that around in about 2 days. And we would then like Utah, make the information public as quickly as possible. And the action can come from our health partners, but also as we're hearing from our management companies and subsidized housing, they are so hungry for information about the health of their residents. They may not be able to isolate their residents or require them to stay home, but what they can do is increase cleaning, increase communication around behavior like mask wearing and distancing. Next slide, please. So our locations and costs, we're looking at non-transient residential locations, particularly our incarceration facilities. There's a lot of interest from our state incarceration facilities, possibly juvenile pre-release season. The Baltimore Housing Authority is particularly interested in serving their vulnerable population. And in Maryland, we often have, in our subsidized settings, elderly mixed in with our subsidized housing communities. So that's another area where we feel like we could do a lot of good with our limited resources. Looking at approximately 50 sites with weekly testing. And the response in an ideal world, and we're all on pins and needles about that CARES money, is testing and tracing, increased cleaning, and of course the behavioral aspects as well. Next slide, please. So what we've done is we've moved from a monitoring approach, and in Maryland, our monitoring was effective. We felt like we could have improved it, expanded it, but our testing turnaround time, thanks to Governor Hogan, is about 2 days. So our ability to give that increased early detection, because we have such great turnaround on our clinical testing, isn't as great. So where could we use this proven concept to affect really positive changes that can save lives and certainly save resources? And the smaller scale buildings, dorms, subsidized congregate housing, and prisons seem to be the right place to put our limited resources. It's about $1 million, and of course it requires engagement and access from the housing community and our health department. So I hope a take-home message that everyone gets is this works best where there are strong trust relationships in a multi-jurisdictional setting that include health leaders as well as wastewater technicians and wastewater leaders, as well as the private entities that are running the subsidized housing. Next slide, please. So we think it's a great way to move forward with using this resource to help our most vulnerable populations. Again, I have incredible leadership in Maryland. There are 2 counties that have also taken on the charge of wastewater monitoring. St. Mary's County is working with a local college, St. Mary's College, and Frederick County is working with their local county health leadership to monitor. I'll tell you, again, I hope we spread the word loud and clear that we are all concerned about the December 30 sunset of the CARES Act, which is going to have a significant impact on our ability to continue this work and other important work to respond to the COVID virus. But we feel that this is a really important tool to help us detect and respond to outbreaks in this next phase of the pandemic. Next slide, please. And with that, I want to mention before I leave a couple of other leaders. Birte Kellerup is a professor at University of Maryland. She's been incredibly valuable in our weekly meetings about this. And Dr. Rita Caldwell, the great Dr. Rita Caldwell, who founded the analytical laboratory that we used during our pilot, has also been a source of great information and resources for the state of Maryland. With that, any questions?
Suzanne, I wanted to ask you about normalizing the data for when, for combined sewer systems where stormwater might be coming in or else other industrial waste might be coming in. And so what is the methodology you're using? Are all the states using the same methodology? Is EPA setting that methodology for you, or is each state using a different system?
Yeah, I think we're all learning the same lessons, and every time that I've had the opportunity to meet with colleagues throughout the nation, I've learned valuable information. So I think there is good information out there, and we continue to learn every day. So with our pilot, I guess the most important take-home lesson is where you can use composite sampling. That is very important. That a composite sampler takes a little bit of wastewater every hour for 12 to 24 hours, however you set it. And if you think about it, people are going to the bathroom throughout the day. You want to be able to sample as wide a diversity of people as possible, not just whoever flushed the toilet right before you took the sample. So that's the first lesson learned. The second lesson learned is, yes, if you are working in a sewer system that also receives some level of rainwater during a rainstorm, and our Cumberland site as well as our St. Mary's County, both of these, the urban areas have that combined sewer and stormwater system. you've either got to be able to standardize for it by measuring flow rates, or you have to be able to maybe delay sampling until 24 hours after rainfall so you can do that. So normalizing the data helped us get better correlations, helped us compare between locations, and it's an important thing to consider as you look at this. Now, I know some states are not doing that, and they are just looking at differences within one site, which is also a reasonable way to move forward.
Okay, and I just have one more question for you, and actually the others on the line too. We had a question about turnaround time from sample collection to getting results to getting information out to the public. So let me start with you on that one, Dr. Dorsey, I should call you. So you had mentioned it's 2 days for the lab to get the results, but what was the total turnaround time from pulling the sample to getting the information to the public or to the elected officials?
Well, thanks to the great work of our volunteers at our wastewater treatment plants, they took the samples and were able to either same day or next day via next day delivery, get the sample to the laboratory. The laboratory typically takes 48 hours if we'd like to pay more. And we used a private laboratory, so we did not use an academic setting. If we wanted to pay more, we could have gotten it in a 24-hour, time frame. And then we could get the information out to our public officials. So within no more than 4 days per site.
And so how about Utah and Colorado? What is your turnaround time from sampling to info?
About the same. Some of our remote sites, it's a day to drive the sample to the lab, but we're looking at about 2 days. And then we have a kind of automated process where the labs submit the data, we QC it, and then it goes live immediately. Our labs can do the 24 hours if it's critical, but we try not to ask them of that too often.
And how about Nicole? How about Colorado?
It's the same 2 to 3 days.
Okay.
And the intention is to have it to go live as soon as it's available.
Okay, well, it looks like we are out of time, but let's go to the next slide. We just have your contact information. So I did want to allow our listeners to contact you with any other further questions that they might have for you. So I also want to thank all of you for sharing your expertise on this, and thank you for all your work helping combat and respond to the COVID virus. It's such an important thing for our nation. So really I want to thank you on behalf of the Governors Association and all the governors. So we're going to have to wrap up now, but I think we could talk for another hour about this great subject. But I want to thank all of our listeners and especially our speakers as well.
Thanks a lot. Thanks, Bevan, for the opportunity.
All right.
Thank you.
Thanks,
Take care.
everybody. Bye.